I'm going to abandon the prolonged banter to which I'm normally addicted and move to the substance of what I want to say, because I want to say a number of things in the time I have. But first, I want to make reference on a personal note to something, and then I have a disclaimer that I'd like to share, and I'd like to provide a word of context. The personal note is an odd one. A number of weeks ago, and it was merely weeks ago, I received an invitation from Archbishop Tutu in South Africa to become an e-health ambassador. You will know that global e-health and telemedicine have come together to ask a number of people internationally to assume roles as e-health ambassadors. And I'm very, very fond of Bishop Tutu, and we are friends, and I have enormous respect for the man, but I declined. And the reason I declined, and because it will speak to something I say later on, is that when I asked for the list of e-health ambassadors, I saw that it was weighted almost exclusively to men. And I will not join panels or activities where men are by gender in disproportionate numbers. I'm deeply offended by it. And I have to say that I was sorry, because it looked intensely fascinating, but I wrote a very respectful letter, which in itself is out of character. Now, the disclaimer I wanted to suggest is that I'm way out of my depth in this crowd and on this subject matter. You'll be relieved to know that that won't prevent me from speaking. I learned a very long time ago never to allow an absence of knowledge to impede opinion. And since I share that view with the Government of Canada, I'm not going to feel self-conscious about disgorging what I came to disgorge. But I am reassured by the program which was provided for this astonishing conference, which I read with an almost religious fidelity every single breakout session. I found the program to be, in brief, both impenetrable and incomprehensible. But I was much taken by a number of the subjects, even though I didn't understand them. And I recognize the wealth of knowledge and expertise which suffuses this audience and clearly manifests itself in the extraordinary work that you individually and collectively do in this world of e-health, and often through the vehicles of the three co-sponsoring organizations of this conference. In fact, because the science and the technology have been covered with such obsessive and fascinating particularity, and I don't say that gratuitously. It is really quite amazing when one reads through the program to see the extent to which all of the subjects have been covered. I'm going to feel that I need not reconnoiter the science, that everyone in this room knows it 1,000 times better than I do. I'm not on Facebook. I've never tweeted in my life. And I just learned about email yesterday. So I am not entirely beyond the techno-peasant phase. And I want you to allow the milk of human kindness to flow through your veins and treat me with compassion. But I'm assuming that the technology and the wealth of experience in the room will exempt me from pretending to cover subject matters that I couldn't possibly handle. The context for what I want to say is, for me, profoundly important. Every document I read in pulling together my thoughts for this opportunity alluded at one point or another to the costs. Alluded to the costs not only within the Canadian framework, but alluded particularly to the costs of e-health as it might be implemented more fully in the developing world, and particularly on the continent that I know a little about, which is the continent of Africa. And the costs were clearly of a dimension that precluded some of the things which governments and people involved in the technology and academics and activists wish to do. And it felt uncomfortable because, of course, what you're doing is improving the human condition. What you're doing is making it possible for personal and population health to flourish in a way it would not otherwise flourish, and to be accessible in a way it would not otherwise be accessible. And so it's painful when costs enter the equation and end up being a determinant of failure. So I want to begin by saying something about costs, drawing on the area that I know best, which is the area of HIV and AIDS. And I want to make this observation. We are, even for those of us who tend to be somewhat skeptical and cynical about these things, we are on the verge of an extraordinary breakthrough around the pandemic. We now know from endless trials and studies that male circumcision reduces the transmission of the virus to the man by up to 60%. We now know, as a consequence of an amazing press conference at the International AIDS Conference in Vienna last year, that there has been the discovery of a microbicide for women which looks as though it will actually work, rooted in one of the antiretroviral drugs. We know by virtue of trials in Thailand a couple of years ago that we may indeed be able to look more auspiciously at the possibility of a vaccine. We know about pre-exposure prophylaxis and what that may mean for particular high-risk vulnerable groups like men having sex with men. We know that there has been in the last 2 weeks an astonishing breakthrough around the use of antiretroviral drugs to reduce transmission to the point where prevention is a concomitant. Back in the year 2006, at the International AIDS Conference in Toronto, Dr. Julio Mantaner, who heads the British Columbia Center of Excellence, brought forward a thesis which seemed so simple and logical that everyone was dumbfounded in its force, but necessarily skeptical because it hadn't been put so persuasively before. And what Julio said, if I may boulderize it, is that when you put people on antiretroviral treatment, no matter how quickly you put them on treatment, even when their CD4 count has not descended below the WHO level, when you put people on antiretroviral treatment, it reduces the viral load in the body to undetectable levels, so that if there is unprotected sex, the transmission of the virus is greatly reduced if it's transmitted at all. And therefore, over a period of time, if you get more and more and more people tested and into treatment when they test HIV positive, at the end of the process, you have significantly and dramatically reduced the transmission and therefore increased hugely the prevention, and so there emerged the mantra, treatment as prevention. And Julio was greeted with a great deal of skepticism, and he was criticized, and he was slandered, and he was besmirched for daring to put a proposition that seemed so simple in its application. And 2 or 3 years later, after there had been more and more intense scientific international discussion, the World Health Organization decided that it would tentatively embrace Julio's analysis, and more people came on board. And then the National Institutes of Health under Anthony Fauci decided to do a trial involving several thousand serodiscordant couples, one HIV positive, the partner HIV negative, and to give to the HIV partner who was positive with a control group antiretroviral therapy, regardless of the CD4 count, and see whether there was significant transmission. And they stopped the trial almost 2 years early, because what they learned was so extraordinary that it would have been immoral and unethical to continue the trials and exclude a control group. They found a reduction in transmission of 96%. And everyone in the international AIDS community suddenly understands that putting people on antiretroviral treatment as quickly as possible will mean over the longer run a tremendous diminution in the number of infections. And there is extraordinary excitement. The executive director of UNAIDS, Michel Sidibe, called it a game changer. Everybody sees it that way. And we're moving towards a high-level meeting on HIV and AIDS at the United Nations between June 8th and 10th in 10 days' time. And we are confounded by an absence of resources. With all of these possibilities in hand, and by the way, with an astonishing New York Times feature in their weekly magazine last Sunday by Tina Rosenberg on the possibility of a cure, not just a vaccine, but a cure for AIDS. And Tina Rosenberg, who's a remarkably gifted journalist who's been writing about infectious diseases forever and does it with a tremendous cachet, Tina Rosenberg makes a case which is almost unassailable in a fascinating proposition about the potential for a cure. So you have all of this coming together, and the replenishment of the Global Fund to fight AIDS, tuberculosis, and malaria fell several $billion short of what was needed. And the presidential initiative in the United States called PEPFAR is flatlining its budget. And there are drug stockouts occurring all over the African continent. And there are a number of projects providing treatment where people who are eligible for treatment cannot get it unless somebody dies who is currently on treatment. And it's such a calamitous sense of wrong. You see, we always have trillions of dollars to fight wars in Afghanistan and Iraq and Libya. And we always have hundreds of billions of dollars for stimulus packages and bailout of banks and corporate bonuses. And we always have oodles of money to fight the war on terrorism and to deal with oil spills. And just 3 or 4 days ago, the G8 suddenly found $20 billion to deal with the Arab Spring, as they call it. And the promises that were made by the G8 at the famous Gleneagles Summit in 2005 in the United Kingdom have fallen between 40% and 50% short of delivery by the year 2010, a promise that seemed to be wedded to those who made it, and instead it is sabotaged and betrayed virtually at the moment it's made. And we can never find a smidgen of those extraordinary amounts of money to deal with global public health. It just drives me crazy. We have money for all of these other, often destructive pursuits in the world, but when it comes to global public health, we have to prostrate ourselves and beg. And I want to say to all of you, because you're right in the thick of it, you're in a revolutionary phase of transforming global health and the accessibility which patients will have and the capacity of the clinicians to perform their arts. I beg you to raise these issues from time to time and to make your voices heard, because you speak with authenticity and force. You have the extraordinary reputation of professionals in a domain which people clamor for, and increasingly will clamor for, because the tide you're riding is irresistible. And if from time to time you said publicly, whether it was true of Canada or whether it was true of the international community, that the priorities are out of whack, that the humanitarian imperative is at least as important as the imperative of conflict, then it would make a great difference. And as you ply your trade day in and day out, I beg you not to succumb to the intellectual nonsense which accompanies the arguments that we're going through some dreadful financial crisis and we cannot summon the dollars to deal with human health. The hell we can't summon the dollars. We can in this country summon tens of millions of dollars for fighter planes, for God's sake. And elsewhere in the world we can summon billions for wars. But again, we fight so relentlessly to find pennies to deal with the human predicament.